Hello? Hello? Hello?
Hello, it's Ashley with CTC. How are you doing today?
Hi. Good. How are you?
Good, thanks. I think we're just waiting for a few more people to join us, so if you don't mind holding on, we'll start probably in about 6 minutes.
Great. Okie doke. I'll be
Thanks.
here. Thank you.
I can ask questions not here.
Hello, it's Alan Bell.
Hello?
Hello.
Hello?
Hello. Hello.
Hi, Dr. Bell.
We got lots of hellos. Hi, it's Alan Bell here.
Hi, Dr. Bell. Raheem Damji as well.
Hi, Raheem. Do we have Andrew on the line or Joe?
Oh yes, Andrew Won is here, Edmonton.
Oh, I'm on the line as well, Dr. Bell. I'll be supporting just as we get started up.
Okay, thank you.
Can you hear me, Andrew?
No, I meant a different Andrew, but that's okay. Hello, Andrew. How are you?
Oh, yes, Andrew Wong. Okay. All right.
Yeah.
Oh, hi, it's Dr. Sharif here.
Hello. Stay on the line. We'll get started in a few minutes.
Okay. How come it's not working?
Hi, are you having any trouble connecting?
Hello?
Hi, did someone say it wasn't working?
Hello?
Hi, are you having difficulty seeing the presentation or hearing anything?
No, I can hear you very well. It's Peter Hum from Edmonton, Alberta.
Hello, Dr. Hung. Glad to hear it's working.
Thank you.
Hello.
Hello?
Hello, this is Dr. Janet Chu.
Hi, this is Dr. Laura Chong.
Yes?
I'm just calling in for this Hypertension Canada. I'm connecting.
Andrew Wong. We'll be starting the conference in just a few minutes. We're just waiting for the host to join.
Thank you.
Dr. Bell, it's Joe. Are you ready to start?
Yes, anytime, Joe.
Yeah, why don't we get started then? I think others may pop into the line, but let's get started. And I want to We're going to unmute the lines. We're going to mute the lines once we start the presentation. But this is Joe speaking from CTC Communications, and thank you for joining us tonight for the @Target program results. I'll be facilitating the presentation tonight, and what we're going to cover off is just this brief introduction, the program results presented by Dr. Ellen Bell, who I'll introduce in a moment. There'll be a Q&A session at the end, and then a few quick notes about the last program steps before we close the presentation. So I would like you to know that we're recording the presentation for future use.
Joe?
We're going to unmute the audience microphones for the Q&A portion at the end. But if you are encountering any technical issues during the presentation, you can message us using the web chat feature, which you can find in the top right-hand corner. Select the chat function, and then you could message Zulamar for technical support. You can also use this feature to send in questions. So let's move on to the presentation, and it's my pleasure to introduce Dr. Ellen Bell. Dr. Bell is an assistant professor for the Department of Family and Community Medicine at the University of Toronto, and he is the chair for the @Target program. We're now going to mute the microphones, but Dr. Bell, I'm going to pass the ball over to you, and we look forward to hearing your presentation. Dr. Bell?
Sorry, I think Dr. Bell got muted. All the different caller IDs is getting very confusing.
Dr. Bell?
Can somebody hear me? I mean, I'm here.
Yeah, here we are, Dr. Bell.
Oh, there we go. Okay.
We can hear you just fine. I introduced you, and we're looking forward to hearing your presentation. So whenever you're ready, please begin.
Yeah, thank you very much. I heard all of that, and I was struggling to talk, but apparently my line was muted somewhere along the line. I still hear a lot of noise in the background, and I'm hoping that we can mute all of the lines as we did on the first teleconference so we don't have dishes and dogs and whatnot in the background, if that's possible. So I would like to start off by thanking everybody for being here this evening. I would also like to thank everybody particularly for participating in this program over the past few months. I know from our perspective as the faculty and at Hypertension Canada, we certainly appreciate all of your efforts in getting this done. But I've got to ask one more time, Joe, I think there's some technical way that you can mute all the lines. If we could do that.
I'm working on it, sorry.
Okay. All right, thank you. Okay, so let's start off by talking a little bit about hypertension. You know, we haven't been talking a lot about hypertension.
Okay.
Hypertension. It's the leading cause of death and disability across the world. We want to talk about financial costs. Hypertension and hypertension-related illness is responsible for some 10% of the total Canadian healthcare budget. We're very proud at Hypertension Canada as an organization that is dedicated solely to the prevention and control of hypertension and its complications. As I'm sure most of you, all of you should be aware, we produce guidelines at Hypertension Canada that are amongst the most credible guidelines in the world and are quoted internationally as a standard in hypertension management. And I think that's largely responsible for the fact that Canada has probably got the best hypertension control rates in the world, approaching 70% of hypertensives are controlled in Canada. So getting back to the At Target program, if you recall, the purpose of this program, the reason that we enrolled you, was we wanted at our end to determine the level of knowledge and attitudes towards the guidelines that Hypertension Canada works so hard on a regular basis to produce, has been on an annual basis, is now going to go on a 2-year cycle to produce. We also wanted to measure the uptake of the guidelines and determine how much they are being used and how effectively that they are being used, particularly in primary care settings, because as primary care practitioners, we really are the purveyors of hypertension management in this country. And we also wanted to provide a learning experience to everybody who participated in this program to be one more step in terms of knowledge translation for effectiveness of the Hypertension Canada guidelines. I was very privileged to work with two excellent other members of the faculty, Dr. Swapnil Hiramath. He is a staff nephrologist at the Ottawa Hospital and assistant professor of medicine at the University of Ottawa, and also Dr. Ross Suyuki, who is a pharmacist, but also holds a professorship, full professorship of medicine at University of Alberta in Edmonton and is director of the EpiCore Research Center. Ross and Swapnil were tireless in terms of their contribution to making this program as effective as it is. So if you recall, we asked you to enroll patients. We asked you to enroll 10 or up to 15 patients, if you cared to, who had either a prior diagnosis of essential hypertension and had their blood pressure measured and recorded in the past 6 months. Easiest inclusion criteria that we could imagine. We just wanted you to get the patients in quickly and easily, and we really wanted a clean, neat sample of in-the-trenches primary care hypertension management. And I think that we accomplished it with that inclusion. We also allowed you to include patients who you had not previously diagnosed with hypertension, but fulfilled high-risk cardiovascular risk factors that match the entry criteria for a very important trial that we're going to discuss in a little bit more detail in a few minutes. That is the SPRINT trial. And those were patients with existing clinical or subclinical cardiovascular disease, patients with prior MI, peripheral arterial disease, or documented atherosclerosis, patients with chronic kidney disease with an eGFR between 20 and 60, patients with a 10-year Framingham cardiovascular risk of 15% or greater, or any patient who was over the age of 75 and had a blood pressure of exceeding 130, equal or greater to 130 millimeters of mercury, but not a history of stroke or TIA, not residing in a long-term care facility, not with symptomatic orthostatic hypertension, not with diabetes, and not with a proteinuria of greater than a gram a day. So any old run-of-the-mill garden variety hypertensive or previously not diagnosed patients with hypertension but fulfilling the SPRINT criteria. Those were the patients that we're looking at. Oops. We wanted you to exclude patients who you felt were inappropriate because they had severe comorbidity and it was going to impact their blood pressure management. We didn't want patients with secondary hypertension. This was not a study for specialists. This was a study for primary care hypertension. And patients with an eGFR with end-stage renal disease or an eGFR of less than 20 mils per minute. So the first thing we did is we profiled you, the participants, the physicians. We had 75 of you. And here's what we found. First of all, in terms of gender, 3/4 of you were men, 1/4 females. It's hard to understand that, but we frequently see that when we do patients participating in practice audits, but it was predominantly a male physician population. Most of you practicing in an urban setting, almost 90% of you practicing in an urban, greater than 10,000 population. Fee-for-service was by about 60% of you were on a fee-for-service model with a quarter on a blended system and 20% on pure capitation, and virtually 100% of you were community physicians and not academic. In terms of where you're from, not unusual in these trials, we see that the Ontario dominated. About half of the physicians were from Ontario, and although some of the smaller provinces had some of the smaller numbers, we were represented well in every province of the country. In terms of years of practice, most of you have been in practice exceeding 20 years, and most of you were in group practices, either a primary care group or a multidisciplinary group, but we still had 28% in solo practice. We asked you the question, how closely do you apply the 2017 Hypertension Canada guidelines to your practice with regard to diagnosis, threshold for initiating therapy, and targeting blood pressure? And we asked 3 categories, always, sometimes, and never, and everybody here breathed a loud sigh of relief when not a single participant said you never apply our guidelines. We were also happy to see that 50% of you, roughly, applied these guidelines to all of these criteria, and the other 50% sometimes apply them, but as in all clinical practice, have some flexibility in what they are doing. I suppose that's why they said sometimes. Then we asked you whether or not we took a guideline that we have, and we said wanted to know whether or not you are using it. Specifically, we asked for non-diabetic patients, do you base blood pressure treatment initiation and targets on cardiovascular risk? And in accordance with our guidelines, 80% of you do, in fact, do that, with only 20% not doing it. And that, of course, is very much a tenet of the current Hypertension Canada guidelines, where the threshold and target blood pressures should be lower than those at greater cardiovascular risk. And that is largely based on the results, as I mentioned, of the SPRINT trial. So I'm going to quickly go over this trial. So the SPRINT trial is asking the question, can lower systolic blood pressure improve outcomes in high-risk populations? And the population that we defined, that the SPRINT investigators defined, was those who were at least 50 years old and had systolic blood pressure of at least 130 and up to 180, and additional cardiovascular risk with, as I mentioned, either clinical or subclinical cardiovascular disease, not including stroke. So coronary disease, peripheral arterial disease, chronic kidney disease with an EFR between 20 and 60, a Framingham risk score greater than 15%, or age greater than 75 years. And I emphasize that these are all ORs. So any one of these would get you into the SPRINT trial. And the SPRINT trial then took this high-risk population and randomized them to one of 2 treatment arms, either the intensive treatment arm where the systolic blood pressure was targeted at 120 millimeters of mercury, or the standard treatment arm where the systolic blood pressure was targeted to what we consider our standard of less than 140 millimeters of mercury. And it's impressive that they did manage to achieve in both of these arms, the 120 and the 140. Patients with a previous stroke, patients with diabetes, polycystic kidney disease, advanced heart failure, advanced proteinuria, or end-stage renal failure were excluded from the SPRINT population. And the results were rather striking in terms of the primary outcome, which is essentially 3-point MACE, but also included heart failure, so composite of myocardial infarction or other acute coronary syndrome, stroke, heart failure, or death from cardiovascular cause. The primary endpoint was reduced by 25%, a harm ratio of 0.75 if you were randomized to intensive treatment with a target blood pressure of 120 millimeters of mercury over a period of 5 years compared to those on standard therapy at 140 millimeter of mercury target. And even more impressive than that, not only did this composite primary outcome achieved, total mortality in the study was also reduced by a striking 27% in the intensive treatment arm over a 5-year period. And these results were enough to make Hypertension Canada as well as other guideline committees around the world, decide that for high-risk patients and recommend that those over the age of 50 years with systolic blood pressure greater than or equal to 130 millimeters of mercury, intensive management to target a systolic blood pressure of 120 millimeters of mercury should be considered. And I point out considered because there are many patients for whom 120 millimeters of mercury may not be appropriate, such as patients who experience hypotension. And we did see that, or patients who are subject to dehydration, we did see actually in the SPRINT trial, along with those very positive results, some negative results as well, including a higher rate of acute renal injury, as well as some electrolyte, particularly potassium disturbances. So we also pointed out at Hypertension Canada that intensive management should be guided by automated office blood pressure measurements, as was done in the SPRINT trial. We all know that if you use automated blood pressure devices, we're going to see a few points lower millimeters of mercury, so we don't want to be using manual measurements to achieve these levels. And finally, that patient selection for intensive management is recommended and caution should be taken in certain high-risk groups, as I pointed out. So our guidelines now have been revised in the 2017 iteration of the document to say for the high-risk SPRINT population, the systolic blood pressure greater than or equal to 130 is an indication for the threshold for the beginning for starting antihypertensive therapy if measured with automated office blood pressure. Patients with diabetes remains unchanged at 130/80 for initiation of therapy. Patients at moderate risk, meaning having any single cardiovascular risk factor, should have therapy initiated at 140/90 if measured manually, 135/85 if using automated office blood pressure. And patients with low risk, cardiovascular risk, meaning no target organ damage and no cardiovascular risk factors, those patients should be initiated on therapy only if they reach 160/100. And in terms of our targets, high-risk patients, according to the SPRINT criteria, should be targeted at less than or equal to 120 millimeters of mercury systolic. Diabetics, the same as the threshold at 130/80, and all others, the same as the threshold at 140/90 manual or 135/85 automated. So that brings us to how these patients should be treated according to our guidelines. And some changes were made in 2017, and I think these are very important changes that I want to point out. First of all, things that haven't changed as initial treatment should be health behavior management. That means encouraging healthy lifestyle with reduced salt intake under 2 grams a day, considering regular exercise on a daily basis, as well as considering some diets like the Mediterranean or the DASH diet, which have also been shown to reduce blood pressure roughly to the level of 1 blood pressure lowering medication. In terms of treatment choices, first-line treatment agents, the same list appears here with diuretics, ACEs, ARBs, long-acting calcium channel blockers, and beta blockers, but we have added single pill combination. Single pill combination meaning that patients can be started on 2 medications in a single pill, combined in a single pill, not as 2 separate pills specifically, to improve blood pressure control. And the single pill combinations that are recommended are the combination of an ACE inhibitor with CCB, an ARB with a CCB, or an ACE or ARB with a diuretic. And in terms of diuretics, instead of using thiazide diuretics, it is recommended that longer-acting thiazide-like diuretics should be used in preference to hydrochlorothiazide or thiazide diuretics. And those longer-acting agents are readily available to us as chlorthalidone or indapamide. Chlorthalidone is a bit of a nuisance because it only comes available in Canada in a 50 milligram pill, and we recommend starting it at 12.5 milligrams, a quarter of a pill, not easy to take. Indapamide is readily available in 2.5 and 1.25 milligram strengths. We also have a little asterisk besides the ACEs and the ARBs, suggesting that we have to be very cautious in patients who are pregnant or contemplating pregnancy. Also a little dagger beside the beta blockers because they are not indicated as first-line therapy in patients over the age of 60 without other compelling conditions. So, getting back to the practice profile, we next, 80% of you, or most of you, said that you follow the Hypertension Canada guidelines. 80% of you agreed that targets and thresholds should be lower for patients at higher risk. So we asked, what do you feel is the appropriate threshold for initiation of therapy, antihypertensive therapy, in a patient who fits the SPRINT criteria? 51% said less than or equal, greater than or equal to 140. 11% said greater than or equal to 120. And on the good news is 39% of you got that answer correct, that patients at high risk fulfilling SPRINT criteria should have blood pressure treatment initiated if their blood pressure is greater than or equal to 130 millimeters of mercury. We next asked you, what do you think is the appropriate target for a patient who fulfills the SPRINT criteria? 17% of you thought it was less than, reaching less than 140. 53% thought it was less than reaching 130. And 29% got the correct answer, stating that it should be reaching a target blood pressure of less than 120 millimeters of mercury if you fulfill SPRINT criteria. So some learning still needed, some work on our part at Hypertension Canada to achieve this kind of knowledge translation for our guidelines. We asked you, you're going to be completing chart audits for 10 or 15 of your patients. We wanted you to estimate what percentage of these patients do you think are at target according to Hypertension Canada guidelines. And you were really quite realistic. The largest proportion of you, 52%, felt 50 to 75% are going to be at target. And that is the national average. About 70% of Canadians do have their blood pressure at target. And I'm going to show you the outcomes when we look at the results of the trials in a few minutes. So a few key points from the guidelines that we really wanted to drive home with this practice audit. One is that automated office blood pressure is the preferred method of performing in-office blood pressure measurements. Two, high-risk patients fulfilling SPRINT criteria, in other words, those with CKD, those with existing cardiovascular disease, those over the age of 75. If you are over 50 and fulfill those criteria, then treatment should be initiated at 130 millimeters of mercury, targeting a blood pressure of less than 120 millimeters of mercury, and we should consider that based on the risks of the patient. We also make the recommendation that longer-acting thiazide-like diuretics are preferred to shorter-acting diuretics, specifically hydrochlorothiazide, and that single-pill combination therapies should be used as first-line treatment. Past iterations of the guidelines had recommended that we only start 2 drugs if the existing blood pressure is 20/10 millimeters of mercury higher than their target blood pressure. From 2017 forward, we do not have that restriction. If you feel that the patient is going to require more than 1 drug, then it is appropriate at any level of blood pressure to initiate single pill combinations of 2 pills in such patients. So, the results. What kind of numbers did we come up with? That was your baseline data. What were the results of this audit? What did we find? Well, in terms of, there were 677 patients audited with an average age of 65 years, 56% men, 96% with a prior diagnosis of hypertension, and the average blood pressure of patients enrolled in the trial, in the study, were 133/79 millimeters of mercury. We asked, what method did you use to measure this patient's blood pressure? And the commonest response, and I think it's very near and dear to my heart, is that automated multiple reading devices were the commonest used in clinical practice, devices such as the BP True. We also saw that another 16% of you are using single reading electronic sphygmomanometers, which again is recommended by Hypertension Canada, over using manual devices, stethoscope and pump. So mercury or aneroid sphygms are not any longer recommended as opposed to electronic devices, either multiple reading or single oscillometric devices. We also see that 5% of you are sending your patients home and making decisions based on home blood pressure measurement. Another highly recommended strategy, helps us eliminate problems that we encounter with white coat hypertension and, of course, the biggest villain of all, masked hypertension. Our enrollment was 46% uncomplicated patients, those without diabetes or SPRINT criteria, We had another 26% with sprint criteria and another 28% who were diabetic. We were very pleased. This was the kind of spread that we were specifically hoping for. Treatment. How are you treating these patients? Well, first question we asked, are you using single pill combinations? We didn't ask you this. We just got it from your responses on the audit. And we found that single antihypertensive pills, SAPs, either alone or in combination were being used by 63%, despite our 2017 recommendation that patients should be getting single pill combinations whenever possible. Single pill combinations were used in 24%, and single pill combinations plus single antihypertensive pills another 13%, making 37%. Not bad. Good start. But still 63% on single pills. The commonest classes were ACE inhibitors, followed closely by calcium channel blockers and ARBs. No surprise there. Long-acting diuretics way down the list at only 6% of patients in the trial using chlorthalidone and indapamide. However, when we looked at the single antihypertensive pills that were prescribed, the commonest, actually the commonest by far as a single antihypertensive pill was amlodipine, followed by perindopril, ramipril, bisoprolol, and hydrochlorothiazide. We see chlorthalidone way down the list, not surprisingly. In terms of single pill combination products by class, the most common that we saw was an ARB and a short-acting diuretic combination, followed by an ACE inhibitor with a long-acting diuretic combination product, followed by ACE inhibitor plus CCB, followed by ARB plus CCB. But ARB plus CCB and others were far down the line. ARB plus long-acting diuretic combination is available, but was very rarely being used in this audit. And in terms of what these pills were, the commonest single pill combination that was used was perindopril, indapamide, followed by perindopril, amlodipine, followed by olmesartan, hydrochlorothiazide. Alzosartan chlorthalidone, I point out, is getting some uptake, as well as, interestingly, atenolol chlorthalidone, which is not one of the currently recommended first-line combinations. How many pills, how many medications are our patients in this trial, in this study getting, this chart audit getting? 38% were on a single pill, 39% were taking 2, and 16% taking 3. These numbers struck me as being quite low, considering most of us know that our patients require 2 medications typically to be controlled. For example, in the SPRINT study, the mean number of blood pressure medications was 1.8 in the standard treatment arm, and to achieve the 120 millimeters of mercury, 2.8 pills were typically required, I shouldn't say pills, medications were typically required to achieve the 120 millimeter of mercury systolic target. And so when we looked at patients who were taking more than 1 medication, we found about half of patients who were taking 2 medications were on a single pill combination. Half were on 2 separate pills. 3, we found that a majority of patients were taking at least 1 single pill combination in that 3-drug regimen. Were we achieving targets? That's the big question that we want to ask. We found in the overall population that about 55% of patients were at target for their blood pressure according to Hypertension Canada guidelines. Patients who were uncomplicated, did not have diabetes, did not have sprint criteria, therefore had the highest target at 140/90. 77% were found to be at target, which is actually above the national average of about 70%. Amongst patients meeting the sprint criteria, where target was 120 millimeters of mercury, 85% of patients were not at target. Again, pointing out to us at Hypertension Canada that we still have a lot of work to do in order to get this guideline and this recommendation translated into general practice. And in diabetic patients, very similar to the overall population, about 58% at target, 42% not. And what this tells us is that the lower the target, the lower the percentage of patients who are going to be achieving it. And I think that's very much in keeping with the fact that some 30% of patients in this audit were only taking a single pill, which typically is not enough to achieve target, even in patients at 140, targeted at 140 over 90. We next asked you, is your patient at target? We asked you to fill in the patient, the details, and the blood pressure, and we said, is your patient at target? And amongst the patients who were at target, mostly you were right when you said, yes, I believe this patient is at target, and if they were at target, you were usually right, 96% of the time. On the other side of the coin, if your patients were not at target, and we asked you, are they at target? For the overall population, 33% of you believed that your patient was at target when in fact they are not, pointing out another educational gap that we have at Hypertension Canada in order to make people understand just exactly what the targets are so they can determine whether or not their patients have achieved it. When we break that down a little bit and take a look at uncomplicated patients, we see that 17% of participants thought their uncomplicated patient was at target when in fact they were not. When we take a look at diabetic patients, roughly the same numbers, 19% of participants, 19% of patients who were not at target were believed by their physician to be at target. And in the SPRINT population, half of the patients who were not at target were believed to be at target. We have our work cut out for us. What impact did this project have on your practices? We took a measure of that too. What we asked is, do you intend to change this patient's treatment? And 70 to 80% of you said yes. When we looked at, this is specifically related to patients who were not at target, we found, as I say, 70 to 80% intend to intensify treatment in these patients. We asked, why have you chosen not to intensify pharmacologic treatment? Is some of this rationale for not intensifying treatment good? We didn't consider this to be a good answer. Patient is close enough to target. You know, if they're not at target, they're not at target. We emphasize the fact that the target is meant to achieve blood pressure control that we specify. 54% believe that health behavior modification will be intensified, and to my mind, that is changing treatment, and I think that is perfectly appropriate. I think that it's very reasonable if your patient is not achieving target before intensifying pharmacologic treatment. It is perfectly reasonable if there is room to intensify health behavior. 27% felt that they wouldn't increase treatment because the patient would refuse it. And I certainly experienced that myself. But I think we have to remember that we don't really know if a patient is going to refuse treatment until we try. And I think it is always worth our efforts. It is the onus is on us to offer the patient intensification of treatment. If they refuse, then they refuse. That is their decision. Concern of causing hypotension. I think that is also an important, realistic, rational concern for not intensifying therapy. So I think that the reasons that patients were not being intensified for the most part were good reasons. We asked, what are you going to use? Are you going to use single pill combination products, or are you going to use single antihypertensive pills? Pre-chart audit and post-chart audit. So pre-chart audit, we knew what you were doing. Here's the red lines. Post-chart audit is the gray lines, and we see that there's a lot more single pill use post-chart audit and a lot less single antihypertensive pill use post-chart audit. So we feel that we have made some inroads. When we do the calculation of what that looks like, this is the baseline use of single pill combination and single antihypertensive pills, with 63% of patients receiving single antihypertensive pills only pre-chart audit, moving that down to 42% post-chart audit, 24% using single pill combinations pre-chart audit, 47% post-chart audit. So I think those are real inroads. I'm going to close with a few key messages. Number one, there's a knowledge gap out there, and by participating in this program, I think that you as participants have helped to close that knowledge gap. I think we at Hypertension Canada still have a ways to go. We want to ensure that blood pressure is measured accurately and that automated office blood pressure machines can more effectively and more accurately measure blood pressure, but if you're going to continue to do it manually, you must do it carefully. It's not something that you just throw in when the patient says, oh, by the way, after you dealt with his 4 existing problems, would you mind measuring my blood pressure, doc? not that easy. It's important that you know the thresholds and the targets, and that the new target for patients at high risk of cardiovascular disease fulfilling SPRINT criteria have a target systolic blood pressure of less than or equal to 120 millimeters of mercury and should be initiated on therapy at systolic blood pressure levels greater than or equal to 130 millimeters of mercury. We want you to consider using more effective therapy, using longer-acting thiazide-like diuretics instead of short-acting thiazide diuretics like hydrochlorothiazide. And finally, that single pill combinations offer significant benefits to your patients in terms of it not only adherence and compliance, but also a number of studies have been done to demonstrate greater achievement of blood pressure targets using these drugs, and in fact, greater reduction in cardiovascular events when single pill combination is used. So on behalf of Hypertension Canada, I'd like to thank you for your participation in this important national initiative. I think it speaks volumes to your commitment to ongoing education in medicine, which I think primary care physicians should be proud of. I also want to remind you that May is Hypertension Month, and that's an opportunity for you to raise awareness, not only in yourself and your colleagues, but also in your patients, to help them know their numbers and get them at target. We would encourage you to visit hypertension.ca, where you can get the latest, greatest information on things like how you can get a blood pressure screening clinic operating at your office, how you can download office materials from Hypertension Canada, including postcards and other patient communications materials. I would also finally encourage you to become a member of Hypertension Canada. Join the hypertension community. Consider joining us at Hypertension Canada. You can contribute. You can be a quiet member. Whatever you do is going to be helpful to all Canadians. It will also help you keep updated with the latest evidence in hypertension, help you to receive free educational material from Canada's most trusted source of hypertension education, and discounts attending our meetings. And I'll stop at this point for any questions if there are any. Thank you.
Thank you very much, Dr. Bell. It's Joe. Can you hear me okay?
I can hear you.
Terrific. What we're going to do now is we've got 40-odd individuals on the phone tonight, so we're just going to keep the phones muted to reduce the background noise so everyone can hear the Q&A, hear Dr. Bell responding to some questions. So if you have a question for Dr. Bell, please go up to the top right of your computer, click on the chat feature, and then you can send a question in to the host. So I've got a couple for you, Dr. Bell, and I'm just going to start with the first one, and then we'll get to the second one. So I'm going to read it out so everyone can hear it. First question is, can you explain who is considered moderate risk versus low risk per guidelines in terms of threshold for treatment?
That's a great question. And I think when Hypertension Canada first came out and said that 160 over 100 as a threshold for treating low-risk patients took a lot of people by surprise. And they said, what? Where did that come from? Well, in fact, these patients are actually quite few and far between. So a patient who has got any single individual cardiovascular risk factor does not fit into that category. So any patient over the age of 50, any patient who smokes cigarettes, any patient who's got hyperlipidemia, any patient who has got a positive family history of cardiovascular disease, certainly any existing cardiovascular disease manifestation of hypertension target organ damage, any single one of those puts that patient into what we call the moderate risk group, where we're going to target initiation of blood pressure treatment at 140 over 90. So I hope that answers.
Okay, here's the next question. Dr. Bell, can you hear me? Dr. Bell?
I think his line may have gotten disconnected. Give him a minute to dial back in.
Sure, let's do that. There's a couple more really good questions that have come in. So as he comes back on the line, I'm sure it'd be worthwhile to wait around for his responses. And I also want to close off with a few housekeeping notes. Why don't I just start with those? These are really significant because we want to make sure you can complete your steps in the program. And what those are following this presentation tonight, the last 2 program steps will be released to be completed on the platform.
Hello.
Hey, there you are.
I'm back. I don't know what happened. I suddenly got a dial tone.
I got a couple really good questions for you.
Okay. I hope I answered
right.
the person. Did you hear my first response?
Yes, we did. Thank you very much. Here's another question for you. So can you elaborate, please, on what thresholds should be for patients with non-diabetic nephropathy?
Non-diabetic nephropathy. Okay, so any patient who has an eGFR between 20 and 60 who is over the age of 50 would qualify as a SPRINT patient. So the initiation for therapy should be at 130 millimeters of mercury, targeting less than 120. Otherwise, if the patient is under age 50, which would be the only reason that they wouldn't have that, or if their eGFR is above 60, which they really wouldn't have CKD, then we would target them at 140 over 90. Initiate at 140 over 90 and target at 140 over 90.
Thank you. Got a couple more for you. So here's one. What is the best oral pill to lower blood pressure, especially in hypertensive emergency?
Oh. Okay, I'll start off by saying that I am not an emergency physician, nor am I an expert in the management of hypertensive emergencies. I think most ER guys tend to use labetalol or hydralazine intravenously, but I have just about enough knowledge on that to be dangerous and not much more, so I'm really uncomfortable in answering that one. What I would recommend is that if we could take that participant's email address and we could address that question and send them a response from somebody who knows what they're talking about.
Okay, that sounds great. We'll do that. And this you may deem this next one to be related, but it's if blood pressure is very high, for example, 200 over 120, do you think this patient should be admitted to hospital?
Okay, so my answer to that would be, I think that's a good family medicine question. I think no. I think we see patients like that, not infrequently. Patients and sometimes healthcare professionals believe that hypertension is a disease that kind of, is like blowing up a balloon too big and then suddenly it bursts. But the fact is that hypertension kills us long and slow, and that patients can run around with 220 over 120 for years before anything terrible happens, but it eventually will. So no, I don't think that that's a hypertensive emergency unless it is associated with signs and symptoms of hypertensive emergency, such as altered level of consciousness, papilledema, that sort of thing. So no, I don't think that patient requires hospitalization, but I think that patient certainly requires intensive therapy. That is clearly a patient who you would start on more than one medication at the outset, preferably as a single pill combination, and follow closely and achieve blood pressure control as rapidly as possible. We've learned from hypertensive trials in the past where blood pressure targets are achieved slowly versus quickly, that we see target organ damage occurring more frequently when more time is taken to achieve targets. So my answer is no, not hospitalization, but yes, urgent, effective treatment.
Thank you. I've got a few more, so take a breath, and I'll run through this next one here. So this one is, can you clarify the should, in quotes, rather than may, in quotes, use SPC, I guess that's single pill combination, as first line? And the follow-up is, they said, I still think there is a place for initiating with a single agent for mild hypertension, in those patients who are motivated to change lifestyle?
Okay. Okay, so I'd like to, first of all, agree with the person in that question. I think that using a single antihypertensive pill for patients who you feel that you can control with a single antihypertensive pill is completely and perfectly appropriate. Many patients, as we know, require more than one medication in order to achieve blood pressure targets, particularly if we're targeting, 130 in the case of a diabetic, or 120 in the case of a high-risk patient, or we've got a long way to go, say 12 or 15 millimeters of mercury systolic. These patients would probably benefit from initial single-pill combination therapy. So we don't have to use SBC in all patients. The algorithm shows SBC as one option amongst all of those. So any single pill is fine, but we urge you to consider SBC, single-pill combinations, up front and not have to wait until your patient is 20/10 above the target. And there's good reasons for that. Reason number one is by using two medications at lower dose, you are going to achieve far more blood pressure reduction than you are by using one medication at high dose. So the previous step-care therapy would recommend starting a single pill at half dose and then increasing the dose and then only then adding on a second pill. What we know is that doubling the dose of an existing antihypertensive will give you roughly an additional 20% blood pressure reduction, whereas adding a second pill, also at half dose, will give you a 100% blood pressure reduction, meaning it will double the effect. So it makes a lot of sense to use two pills at half dose rather than starting at one pill at half dose and then adding it into a second dose. Further, at half doses of medication, we see far fewer side effects. 5 milligrams of amlodipine is associated with far fewer side effects than 10. I'll use a bad example by saying hydrochlorothiazide, but 12.5 milligrams of hydrochlorothiazide is associated with a whole lot less side effects than 25. So by combining two half-dose medications for initial therapy, you are much more likely to get that patient more quickly to target with fewer side effects.
Great. Thank you. One of the comments was asking you, posing a question to you, why do you say avoid beta blockers in greater than 60-year-old patients unless other compelling reasons?
That comes from the All-Hat trial, I believe, where they failed to show benefit in elderly patients with the use of beta blockers. Now, that being said, there are very specific patients in whom beta blockers are perfectly appropriate first-line therapy. For example, patients with coronary artery disease, patients with previous vascular events, beta blockers would be a perfectly appropriate first-line therapy, in fact, a recommended first-line therapy in patients regardless of their age in that population. So when there are compelling reasons to use specific antihypertensives, then they certainly should be used. But the algorithm that I showed you was for uncomplicated hypertension, where there are no compelling reasons to use specific agents. So the bottom line is that beta blockers have not been demonstrated to provide benefit to patients in terms of cardiovascular risk reduction in patients over the age of 60 without compelling conditions, which is why the recommendation is there. It's very difficult to remember all the lists of medications that are recommended first line in patients with compelling indications, which is why Hypertension Canada produces a booklet every year with the highlights of the guidelines that always includes a section on therapy for specific and compelling indications, such as renal failure, for example, where we recommend ACE inhibitors up front, diabetes with or without the presence of proteinuria. It's all laid out in there, but please don't ask me all the questions about that now. I don't have that booklet in front of me.
Fair enough. There's a comment. I hear BP True has been discontinued, and they asked why.
Okay, I have no clue why, but I know that it's caused a tremendous frustration in my office when our BP True, we use two of them in the office, wheeling them around. Our BP True died, and not only could we not buy another one, we couldn't get it repaired. So we've replaced it with another device now, the Welch-Allen device, which is actually kind of neater and cleaner, and it's a lovely device, and we're perfectly happy with it. So why it's been discontinued, I have no idea, but we've always found it to be a reliable device. I don't know what happened on a corporate level, but there are many other devices that are available. Omron makes one, as I mentioned. Welch Allen makes one. They cost about $800, including the thing that you can wheel around your office. And I would urge everybody on the call, if they're not already using an automated device, to go out and get one. It saves you. Not only does it give you a more accurate blood pressure measurement, not only is it compliant with what blood pressure devices are used in important trials like SPRINT, but it also saves you a ton of time. You know, in order to measure blood pressure properly manually, that patient has to sit quietly for 5 minutes before you start. That patient has to, there are just so many requirements that take so much time. You have to be there to actually do the blood pressure measurements. That probably has an impact on the blood pressure measurement, just having an observer present. So putting the device on, pushing the button, and going to see another patient is a whole lot more efficient way of doing things, if you ask me, and effective.
There's a comment posted here in the chat room, as you can see, that confirming that it has been discontinued. No other company has picked it up, and Hypertension Canada's BPM recommendation program will soon list clinical-grade devices.
Right. Right. There is already, Hypertension Canada also already lists gold and silver devices that are for consumer use, is my understanding, and will be listing similar recommendations for office devices, to the best of my understanding.
What about bringing down the blood pressure quickly? Are there any risks of inducing stroke?
I think the only place that I'm aware of any recommendations specifically in that regard are in the acute stroke situation, where patients have had an acute stroke and you don't want acute ischemic stroke, and you don't want to risk reducing perfusion. My understanding is that again, this is an environment that I don't work in, so I'm no expertise in this, but in that situation, blood pressure should be reduced according to guidelines recommended by the current stroke practices. I don't think there's any concern of causing stroke in patients otherwise by reducing blood pressure quickly. But I think what we're going to do in the long term is reduce strokes, not cause them.
What about risks? Are there any if you're giving ASA 80 milligram to a patient with very high BP?
Anytime that we're using any antithrombotic medication, whether it's an antiplatelet medication or an anticoagulant medication, blood pressure must be controlled. So one of the recommendations from the Canadian Cardiovascular Society in the atrial fibrillation guidelines, as well as from Thrombosis Canada in our clinical guides on management of anticoagulants, is that in order to prevent bleeding, particularly intracerebral hemorrhage, blood pressure should be well controlled. So I guess my answer to the question, I don't remember the exact wording, my answer is getting blood pressure under control in patients who are receiving antithrombotic medications is of particular importance to prevent the complications of the antithrombotic, particularly intracranial hemorrhage, the most feared complication.
We've got a couple. Oh, yeah, here's one. So how aggressive would you treat if systolic is at target, but diastolic is not, or vice versa?
Right. The guidelines specify that both must be achieved. So I would not change my aggressiveness in terms of treating them, whether it's isolated systolic hypertension or systolic diastolic hypertension, or the rare situation of isolated diastolic hypertension. So the short answer to that question is and again, under the compelling indications section of the guidelines, there are specific treatment recommendations that are more appropriate for ISH, isolated systolic hypertension, as opposed to the more common systolic diastolic. But again, you're going to be as aggressive as you need to be to achieve targets. And the guidelines are pretty clear on which drugs to use. Start with any of them, then go on to combinations, or start with a combination, as we've been discussing.
Two more. Is 10 milligram amlodipine and 14 milligram perindopril less likely to cause swelling of the legs than just the 10 milligram of amlodipine?
Yes, apparently that's quite true. Exactly why that's true is unclear, but combining an ACE inhibitor with a long-acting calcium channel blocker is associated with less edema. Please don't ask me the mechanism for that. I don't know, and I suspect that anybody who tells you they do know is lying. But that is an observation. You can help manage the edema associated with non-dihydropyridines by adding a RAS agent.
Here's an interesting one. Why would there be different BP targets for different risk groups when it has been shown that in native wild populations with no access to civilization, the normal BP is 120/80?
I'm not sure how those two things are related, but the answer is that lower blood pressure targets have been demonstrated to provide greater benefits for patients at higher risk. I think it's a whole question of absolute benefit versus relative benefit. If patients are at higher risk, then reducing that risk is going to give you greater absolute numbers of patients who benefit. So bottom line is, the higher your risk, the more aggressive we need to be in managing blood pressure. Okay. And I'm really not sure how that relates to native populations.
I'm going to, if there are any other questions, please send them along. Thank you very much, Dr. Bell, for working through those. There was a lot there, and much appreciated. I'm sure it's appreciated by the attendees as well. We had a large audience tonight of about 40 or so, and I'm sure they valued both the presentation and your responses. We've got a couple minutes, so if there's a couple other questions, feel free to send them along. I'm just going to complete a couple of housekeeping notes. So following tonight, there's 2 program steps that are left. And these will be released on the platform where you've done your surveys. These include viewing the results report for the program. This is really interesting because you'll be able to view your personal data mapped against the program data, meaning all the other participants' data. So it gives you a wonderful insight in terms of what you're doing versus what everyone else is doing. Please note that when I speak to these personal results, you are the only one that has visibility to those results. Completing that step leads you to the final step, and that's to complete a brief exit survey on the program. And this is very valuable information should future programs be pursued similar to this. And it won't take that long. Probably take you about 10 minutes to complete those 2 steps. Please complete by May 31. That'll enable us to facilitate the sending out of your honoraria. And you'll receive a reminder email following the session with your program details, just in case it's been a while since you've been logged in. And the honoraria will be sent out to the address you entered when you completed your participant contract. So we have that information. So in closing, I'd like to note that this program importantly was supported by a non-restricted educational grant from Servier Canada. I'd like to thank the chair, Dr. Bell, once again for the presentation and his responses to the many questions that came in, which obviously show the interest in tonight's presentation. Any questions regarding the program, Ashley Folkard, who you've communicated with throughout this program, please feel free to send her your questions, and she'll be happy to answer those. And thank you very much for your time this evening. We're going to finish right on time. And thank you again, as Dr. Bell stated from the beginning, for your participation in this program. We really hope you thought it was valuable, and please complete your last 2 steps by May 31st. Thanks again to everyone for participating, and to Dr. Bell, and wish you an enjoyable rest of your evening. Good night, everybody.
Thank you. Good night.